What we might do before we go into the, we won't maybe do questions directly now, but we're going to open the panel, and I'd just like to introduce our panel, and each panel member, if you're happy to just share a little bit about your program, and then we'll, excuse me, I've got to go through the app here. We'll open the floor for some questions particularly, and you know, bear with us, it's good to actually see how these applications work, so I'm really grateful for everybody's patience this morning. So firstly, I would like to introduce Maggie Beiser. Yeah, great. Okay, so Maggie's from Boston Healthcare for the Homeless program and is an adult nurse practitioner with this program where she provides primary and specialised HIV, HCV addiction and gender care for people experiencing homelessness and or using drugs. She founded the BHCHP-HCV treatment program and leads its educational research and advocacy efforts.
Dive in? Okay. Hi, everybody. I'm very happy to be here. So, as Alex said, I'm a nurse practitioner, but Boston Healthcare for the Homeless program is a pretty amazing and unique program that is really founded in nursing principles from the very beginning. So, as an organization, we are a primary care community health center, but we operate at over 30 sites, and many of those sites are shelter-based clinics that were originally nurse clinics entirely, and still really are nurse-run with an overlay of clinical primary care and work. And over the years, we have flexibly tried to respond to a number of crises in our patient population. First TB and multi-drug resistant HIV in the 90s, and then more recently the overdose crisis. 1 in 4 of the patients that have died in our practice in the last 20 years have been from drug overdose, and we have fentanyl in Boston pretty much exclusively. But we have risen to also respond to COVID and to integrate PrEP and to integrate very low threshold prescribing of office-based buprenorphine and a number of other cool things. And I just want to highlight sort of where nursing has emerged as the key component in those programs. So I started the Hep C program 10 years ago, and I love it, and I could talk about it forever, but I'm going to skip over that just to talk also about some other things. So we have a buprenorphine treatment model that is it's almost essentially nurse-led. So our nurses see patients usually weekly or more frequently or less frequently in person or via telehealth. They independently work on dose adjusting medication to meet patients' needs. They do the full range of harm reduction counseling and support. We also have a pretty unique program called SPOT, which is the Supportive Place for Observation and Treatment. It was the first of its kind in the country, in the States. And it is a place we don't unfortunately have drug consumption rooms where we are, but it is a place where people who have used substances can come and just be in a safe space. So they may have oxygen monitor or oxygen delivery. They may, in some cases, we can do IV fluids. They have vital sign monitoring. They're Jerry chairs. People can just sleep if they need to sleep. And if they are amenable, if they're awake and want to also address health needs, we can do that. If they're interested in treatment, we can do that. If they're interested in medications for opioid use disorder, we can, but we don't have to. We don't take names unless people want to volunteer that. It's an incredibly low threshold space, and that is run by the nurses in our program. And they have also developed a sedation monitoring protocol that is really pretty revolutionary. So we talk about naloxone a lot here, but we have found that, unfortunately, naloxone can cause some harm for our folks as well. And so we have the 4 milligram intranasal spray. We've shifted much more to using the 1 to 2 milligrams, like a whisper of naloxone in some cases. And in many cases, we're working to try to only use oxygen when we can. And so that has been very nurse driven. Another area has been in HIV prevention work. And so we had an HIV cluster of infections among people who are homeless and injecting drugs in a half-mile radius of where we operate. And over about 3 years, we had 145 new cases of HIV. And so the response for that was really massive and rapid. Unfortunately, not rapid enough. But to prevent more infections. But one of the ways we have done that has been to empower our HIV prevention and screening team, who are mostly non-clinical staff and are doing serum-based testing, and it's syndemic testing. So all of that testing is HIV, hepatitis C, syphilis, and then if people are able to do urines, chlamydia and gonorrhea. We also do HIV RNA testing every time in the context of this very high incidence rate, and PrEP prescribing either via telehealth, like the case manager would say, I did labs, can I call you? And I would be on the phone with the patient and the case manager and facilitate evaluation and prescribing in that moment, and then putting medication in that person's hand for right then, with nurses in our outreach setting holding medication, delivering it on a directly observed therapy basis or a weekly basis with pill boxes, and sort of really flexibly trying to respond to whatever people needed. But also we developed a nursing standing order, so nurses could do that evaluation, making sure people don't have signs of acute HIV infection, they don't have hepatitis B, and then being able to start 7 days of TDF in our case. While waiting for test results, to really we cannot lose people in that moment. And so nurses have just been fundamental to that situation. I think those are the big things I wanted to pull out. Also, wound care, we have quite a bit of xylazine contamination in our fentanyl. And my colleague Taya Johnson is a nurse practitioner. She did a great podcast on the curbsiders, if you're familiar with. It's a US doctor-based, mostly educational podcast, but she has developed amazing wound care resources for xylazine wounds, and that's available for free on a podcast called The Curbsiders. And then in general, our program is deeply, deeply nurse-oriented. I'm one of 45 NPs in our program. We have over 250 nurses who work across our program. We have, like I said, 30 sites. We see about 10 to 11,000 patients a year. And then we also have a medical respite program, which is 100 beds for people who are too sick to be really in the street or on the shelter with an acute level illness, but not really hospital level of care. And so we do, that is it's 24/7 nurse provided, and people meet with a medical provider every day, and that's often a nurse practitioner to address the entire scope of care, from harm reduction, addiction treatment, but also colonoscopy prep and hypertension management and diabetes stabilization and HIV stabilization, and sort of bringing the full scope of primary health care to the most sort of low threshold sites to try to really improve the health, the kind of holistic health of all the people we take care of. And I'll stop there.
Holy moly. Such amazing programs, and hearing some of the intersection of both yours and Martha's, the importance of PrEP in that population where you had the HIV cluster, so important to be able to get out there quickly and be reactive. And what a huge network. And all those nurse practitioners. I don't know who's jealous, but I certainly am in Australia, where they're very limited in comparison. So amazing. Thank you so much. Now I'd like to hand over to Brett. Sorry, here we go. Brett is from
New Brunswick, Canada.
Thank you. My phone's seized up. Yeah, awesome, please.
Yes, my name is Brett MacDonald. I'm from New Brunswick, Canada. I have a shared capacity with partial work in the ER. In Fredericton Square, kind of got my grounding post nursing school, and I work at Riverstone Recovery Center as well. We have 3 posters, 86, 87, and 88, if you'd like to stop by and see them. I joined the panel because this is more, the chemsex in relation to the LGBTQ community is very much an emerging dynamic patient population, and I feel like it needs some priority work. Myself, in full disclosure, I did legal pornography to get through nursing school, so part of working sex trade and understanding the safeties and parameters in harm reduction for myself. I'm also in a committed relationship with my partner, we are in an open relationship. Both of us are on Doxy PrEP, so it does work, it is efficient. I would be more than happy to answer any questions for nursing considerations, how those aspects work. Education is very expensive, so lots of people find different means. Most chemsex integration or talks, at home we call it P&P, or party and play. It's usually in a dark form, or folks usually view it as like a very dark intersection of how people work or maneuver the system to gain funds. OnlyFans is another way. All are legal. My bosses know. And so does my governing body that holds my license, because I only processed in the legal system. But also along the way, I do have friends who have kind of lost their way with chemsex. Some have lost their lives. So it's very important that this area of harm reduction is talked about openly in spaces like this. The dynamic examination of how this works, what's the drivers, how to keep people safe in ongoing sessions like that. So yeah, as for nursing considerations, I wrote down quite a few, and it kind of mirrored our gal's presentation here today. But mostly it's just understanding, in certain care areas such as the ER, such as the medical floors in our area, the vast workload that nurses are experiencing now may lack, partial empathy for some of these folks who may miss things. Wonderful things that we do at Riverstone Recovery Center for harm reduction is we also have open capacity for a lot of sex trade workers as well. So keeping those folks safe, and it's really great to say to somebody who is processing sex trade that, hey, I do doxy prep, it's fine, I'm here. And we don't necessarily share our experiences with our patients as much unless it can be documented, because when you self-disclose, sometimes they can turn it around and use it against you. So in your self-disclosure of how you provide care for your interventions for folks in this area, as long as it can be measured, documented, say, hey, I'm on it, it works for me, I'm here now, these are my results, I haven't, and honestly, over the past year, I have not had any other infections, co-infections, and I believe that's primarily due to the new Doxy Prep program that is facilitated in Fredericton. Now, my family doctor is not able to take my partner on as primary care just due to the capacity that she carries, but due to our openness in our sexual activity, has agreed to provide scripts for him for PrEP. And I know that there's a lot of issues throughout our country, especially with the lack of education in New Brunswick around this type of care, and especially those living with or affected by HIV. So I would empower all of you nursing staff or nursing folks to really engage in your LGBTQ communities who may be taking part in these activities, that there are answers, and to keep pushing for if you cannot find somebody to provide PrEP. Also, and with the doxy as well. Also, I've heard some emerging issues with other nursing care trying to provide PEP with their folks who may be injecting drugs as well. That should be a no-brainer because obviously the cost to the healthcare system for ongoing ART therapy is very expensive. So if you can upstream that and provide that care, would be very beneficial. So yeah, I would be very open to answer any questions that folks may have in regarding those two areas, and that's why I joined this panel.
Yeah, amazing. It's amazing, Brett. Thank you so much. And one of the things that I was thinking during the first session and also the second is that the use of the value of peers in all of our areas, but particularly in this area as well, because it's a very sensitive, private area that people may not actually want to disclose. And so great respect for that. Okay, so now our third panel member, Phumzile.
Phumzile.
Yes.
We're very close, I think.
Please, welcome.
Okay. Hi, everyone. My name is Phumzile Mngomezulu. I am from South Africa. I work for an organization known as TB HIV Care, which is in 3 provinces where PWID, which is People Who Inject Drugs program, is concerned. Namely, it's in Tshwane, another one is in Durban, and also in Mpumalanga. So, our PWID program consists of health professionals. We have qualified nurses that prescribe and manage ART and PrEP. We have social workers. We have peers, which play the most vital role. I think that is something that is very common because of most of our peers are also from the community. So it becomes very easier for them to actually relate and be the forefront when we need to provide our services. So our services are offered in our drop-in centers, but there's only 10% in the drop-in centers. And 90% is actually on outreach. And some of the biggest challenges in South Africa, and mainly with people who inject drugs as a key population, is the homelessness. So we have over 70% of people who inject drugs that are homeless, which makes it a bit difficult to actually try and, when I was listening to other presentations, there were so many innovations. There's telehealth, there's this and that, and I was here thinking, this is a dream for some of our programs in South Africa because we are still relying on ensuring that we adhere to a schedule because our clients do not have cell phones. If we miss a client at that particular time that we were scheduled, it means that client is going to go a full day without their treatment. They're going to go a full day without their methadone. So chances of us finding that client, they are slightly slim. So we really, really try in our model of care to ensure that among everything that we do, that we provide, we always stick to the schedule. And the clients know exactly where we are at what time, unless if there's an earthquake, which is unlikely. But we really, really try to make sure that the services are delivered to them and on time. We also have a very high positivity rate. So there was a recent biobehavioral survey study that was conducted at TB HIV Care, led by our consultant, Dr. Andrew Scheiber. In one of the 3 provinces, we had a 72% HIV positivity rate. And we had 71% of hepatitis C. So it's amazing to see what other countries are doing. And then again, when I look at it and understanding that we are from a third world country, some of the things we look from a distance and say, it would make such a great difference if we had those opportunities, if we had those models of care also in our country. And to try and make sure that there is, continuous service, we actually combine our comprehensive service package where there's HIV counseling and testing. So our peer educators are well trained and certified as HIV testers and counselors, and we provide also index testing because we have found that there is more transmission of HIV through the sharing of injecting equipment. So we do that through index testing. And there's also social network strategies, which is very good in terms of helping us find more clients. So a client will come and, would say, I've heard about the services from a friend of mine when we were incarcerated. So this is how it now opens up to more PWIDs actually accessing the service. And we have adherence clubs as well, with a form of support groups where we look at clients that are initiated on art, and we try as much as possible to have motivational activities to actually keep them on art. Our PrEP uptake is also a bit low because we are still using oral PrEP with the hope that we'll also be able to transition to the injectable PrEP. So HIV prevention is also strengthened through the needle and syringe program, which we're really, really trying to strengthen and make sure that there is consistent supply and a lot of health education. Because we can provide all of these services, but if a client does not understand the need, to prevent HIV, to protect themselves, then it is just all in vain. So part of the complementary services that we provide, because of, most of the basic needs of our homeless PWIDs are not met, we really try to actually give them something that is going to motivate them to also consider their health as a priority. So this includes our shower facilities. We have shower facilities. We have areas where they can wash their clothes while they're taking a shower. And we also have like a cool space where they would just sit, do some artwork, and it has now changed into an income generation activity where we're working together with COSA. With Sanput. So what we've actually found is that the more clients that we enroll on, OAT, once they are now in the space of deciding what they want to do with their lives, if there's nothing that is keeping them busy, it becomes easier for them to literally just go back to that corner. So we keep them occupied, and at the same time, they make income out of all the hard work that they would have done. And we also provide dignitary packs where it's tailor-made for women, also tailor-made for men. So these are some of the little things that would be taken for granted, but it actually plays a very vital role in each of, in each of our clients. And then we also have daily nutritional packs that we're providing, because most of them don't even know when their next meal is gonna come from. They hustle, in South Africa we call it Zula. So we really try to kind of give them something. And on Fridays, we have a hot meal Fridays where the team would cook up a storm, like a full plate of food with several colors. And it's something that they also really appreciate. And during those times, that is when we get the opportunity to also engage with them. That is where we also find our lost to follow up clients and like, no, come back. What happened? And then, so it gives us that ability to bring them back to care, and at the same time, just keep on building those relationships and giving them a home, if I may call it, or a safe space. Yes, and some of the challenges that we are experiencing, there is still some confiscation and arrest from the police officers. Sometimes you'd find reports that they've actually confiscated needles that were still sealed in a pack, and there are certain boundaries or challenges that at this point we really trying at our level, at our capacity to try and breach, and that would be through continuous sensitization, just going to those police stations, just trying to engage with them, make them understand our services, and also invite them to all of our service points, and whenever we're doing an outreach or any kind of promotional program. But we win with some it's still, it's still a battle, but yeah, we're sticking to it. And we also have some reports around the ill treatment in the public health facilities, just because a client comes in looking for service and they don't look hygienically well, or they will be kept waiting for like 3-4 hours, and at the same time, if the client is now withdrawing, the need to seek service will no longer be there, and they will leave without getting any services. So we really try to strengthen advocacy while also trying to do at what we can at our capacity. And some of the strategies include also community advisory groups where we try to engage with clients just to find out exactly what is it that we need to do for you. Because of sometimes it's easier for us to think the clients need this, the clients need that. But when we engage with them, we actually are able to find out exactly how we can restructure our programs to better suit their needs and actually deliver the service that they really need instead of what we think they need. We've also developed strategies like a buddy system, because we've seen that mostly clients that are having a next of kin or support person are more likely to be retained on treatment. However, those that are homeless, it's unlikely for them to have like a mother or a brother who would come in. So we have a buddy system where it would be 2 clients. If they're sleeping in the same area, maybe under a bridge, and the other one is unable to make it to the facility, the other one would be able to take their treatment for them. And we'd also formulate those support groups where they continuously engage and they understand, and they would remind each other to say, no, I can't pick up treatment for you this month because you remember you need to take your viral load. So it becomes very much of a community that is surrounded by support, and in turn, they become the support structure for each other. Yeah. So I think that is basically that. There's a lot that we can really talk about where our program is concerned, but mostly it is, if we were to compare with any other countries, I think we are still at the level where we are looking at what is best for the person at this point, and it really plays a vital role. Thank you.
So many wraparound services there. It's inspiring, and there's this theme through everybody's talks around homelessness. I think that's something that we are constantly addressing, is the socioeconomic challenges of our clients, and so it's amazing to look at all those packs and the provision. And I love the buddy system. I love that, because I often see the guys that I'm working with who are living rough or at risk of homelessness, that they do actually look out for one another. There is a community there, so it's great to actually involve them in their own care and also their comrades. So thank you so much. So we have actually got 20 minutes of this session. It's quite a long session, which is great because it means we've got an opportunity to open the floor to questions. I also do have some plants in the audience who have their own models of care, which we really love to hear about. If there's other questions and you want to answer those, please do. Would you like to just firstly stand up and identify yourselves? Just to say hi. Plants. But not. We had lots of EOIs, as I said, and I just wanted to, bring everybody to the forefront. So, Lucy?
You do a great job. It's a great job.
Frontline nurse practitioner with Doctors of the World in Montreal. I work at a nurse-led proximity clinic in the Native Friendship Center downtown Montreal. So our clients, our patients are mostly people. Everybody who spoke has the same type of patients. And us, it's mostly Indigenous, and it's Indigenous-led. I'm Indigenous also. So it helps a lot for Indigenous patients that are homeless, vulnerable, HIV, hepatitis C, have problems with addiction, to be in a safe space that is Indigenous with an Indigenous nurse, and we have traditional healers that we work with also.
Amazing.
But we have our challenges. Means to contact our patients are difficult. Phones are lost, sold, or non-existent. And there's many, police is also a big issue. We have a lot of problems with sex trafficking, especially our Inuit women that come from the north and are brought to the south being Canada, Montreal, for sex trade. A lot of violence, gender-oriented violence towards our LGBTQ and women on the streets. So it's a challenge, and I think everybody gets it what it is.
Yeah. Fantastic, thank you.
Hello, my name's Pam Ford. I'm a nurse in Regina, Canada. I work with a team of outreach workers and lab techs, and I have peer support who has lived experience, but he's now a social worker, although he doesn't tell anybody that he is.
That's amazing.
They just know him as Rob on the street.
Yeah.
And we don't have a clinic. We are completely mobile, so we are in all of our community centers that we would go to, so needle exchange, soup kitchens, drop-in centers. We have one safe injection site, and we go in, we offer testing for Hep C, HIV, syphilis. If they have a bathroom, we'll do the rest of it. We do offer incentives to get people to encourage them to be tested, and then we connect them to care. In my province, our government has ridiculously decided in February to not allow us to give out supplies for inhalation any longer, so we no longer have that option. So when I do get funding, I actually use that funding to buy pipes. Our program in our province has always been a one-for-one needle, but it used to be that if you had no needles and you walked in and you asked for needles, you get a 10-pack, so you get 10 needles. It's now back to one-for-one, so if you don't have any, you don't get any. We've seen a significant change in people that were smoking, switching back to needles, because at least you could get a needle. So of course, lots of people are using, a lot of shared equipment again, because access is not as easy as it was. The talk that was earlier today, they were talking about the different things that they use for smoking with. Ours, a lot of them use light bulbs now. I was like, what the hell? Why are we finding all these light bulbs all of a sudden? But yeah, light bulbs is a big one. So yeah, just, that's not really what I do, but we see it as a need to offer. So we, it's also an incentive. They'll come in and get testing because they know they can get free supplies from us. So doing all that, and majority of my people are also Indigenous. I live in a province where it's a high population of that. Most of my people that I see also live rough. So I live in a province where in the winter, -30 is very common. So living rough is really, really rough.
Really rough.
So, we also, from October to about May, we have some warming centers that are open from 9 p.m. till 7 a.m. So we also have staff that go in and help to offer testing and things like that, so.
Amazing. And how challenging when you had something and it was taken away.
It's
You just think we're going to keep moving forward.
Yeah.
But then when something like that happens, that could just be so difficult to, like, I really...
Yeah.
That's
We were
hard.
thinking we were finally sort of getting on top of, from COVID with all the restrictions that we had. And although we did have needle exchange and things were open during COVID, it was limited hours and limited, access to it because only one person could be in the building and made it very difficult. So of course our numbers, all skyrocketed and, we were just starting to see some, maybe significant change where it was going back again, and we're right back to that all over again, so.
Thank you.
I'm Ann, a nurse from Kool-Aid, and I think I've spoken earlier about the programs that we do regarding people experience homelessness, but we also have a sexual health program that I thought I would just highlight here. In Victoria, when PrEP first started, we had no family physicians who were willing to take it on that we could find. And so because our physician group is really passionate about helping underserviced people, they agreed that nurses could start a PrEP program and they would oversee writing the prescriptions. But the nurses did sort of all the legwork. So we have a drop-in every Thursday night for 3 hours. It's a men's testing night, we call it. We've partnered with AIDS Vancouver Island, and they have an outreach worker who sits in our waiting area and provides information for people who would like it. And then the nurses we go out, we have 2 nurses working that evening, and I would say in the average night we see about 15 men per night for initiation of PrEP or STI testing, doxy-PEP as well. And fortunately, we just do all the blood work and all the testing on site. And we also are able to treat people for STIs on the spot as well. So if someone comes in symptomatic, we can treat with the medications. We do a lot of syphilis testing. Interestingly enough, we are not seeing a ton of syphilis in our men who have sex with men population anymore. It's jumped over, and we see it in our primary care practice, just in the general population that we serve. So that's an interesting phenomenon, and I think probably speaks to the engagement of this population in health, the frequent testing, getting treated right away if they're positive, so you're just not seeing the same transmission level there. We also go out to Beacon Hill Park in Victoria, which is a common cruising area for men, probably more commonly men who are on the down low, if you will. And so we take out our mobile van, and we have a peer worker and a nurse on the van, and people come in and get tested anonymously. They can pick up supplies, and so we do a lot of point of care testing. We take our immunizations, so we do Hep A, Hep B, HPV immunizations on our outreach, also on our men's testing night. We also have a women's testing night, so we go out on our van just twice a month with our local agency called Peers, which is a old-fashioned name, Prostitute Empowerment Education Resource Society, but basically it's a service for sex trade, women who work in the sex trade. And so we partner with their vans, so our 2 vans park together in the evening, and again, we have a physician and a nurse on the van, and we have the capability of doing full pelvic exams. We will provide medical abortion, we provide birth control, and then we also, at that time, will start people on OAT, whatever needs to be done, we do. And that's twice a month. And then we have a women's clinic in the health center that does, we'll put in IUDs, do endometrial biopsies, again, the medical abortion, whatever needs to be done. And that is, we have a female physician and a nurse on site for those nights. And again, offer PrEP for women who work in the sex trade. As people probably are aware, there's not enough evidence right now to support doxy-PEP, the doxycycline for the chlamydia gonorrhea. We've just recently written a letter to the BC Centre for Disease Control, which is the agency that controls it at the dispensing of the publicly funded doxy, to try and get them to do some studies, because there's one study out there that shows there might be some benefit for women who work in the sex trade. And so we're really advocating to get more research. So if anyone is looking for a research project, I would encourage someone to maybe consider doing that. Thank you.
Awesome. Thank you, Anne. So many incredible programs. So if I'd like to open it up to the floor for any questions to our panellists, to our speakers. Please, a couple of microphones, please do. Yeah.
Hi, Brendan Harney. I'm originally from the Burnett Institute in Australia, currently in Montreal at the University of Montreal as a postdoc. I like to say in these sessions I'm not a nurse, but I've worked with nurses. I love everything you do, so thank you so much. So my question was for the guys from London. So you presented some incredibly high rates of STIs. First question, was that active syphilis?
Yes, most of it was.
Okay, wow, yep. And in terms of chlamydia gonorrhea, Julian, we spoke yesterday briefly. Is that just vaginal swabs?
So we do oral, vaginal,
Okay.
and rectal swabs or a urine sample.
Okay, cool.
So it's
yep.
whatever they say, whatever type of sex they say they're having, then we'll offer.
Okay, great, because I think that's like a major ongoing issue. People aren't doing the other sites, and in Australia, we are pretty lucky. Sex work is, we are quite progressive. It is, quite, it's essentially fully legal, but we are seeing slow upticks in STIs among sex workers, and we think it's because of oral sex. With no one uses condoms for oral sex, right? Yeah. So yeah, great to hear. Thank you so much.
Thank you. Yeah, Leah.
Thank you, everyone. Just mind blown. So many questions. I think everyone's just doing such important work. I have some theme-based questions, and really anyone could take them around HIV prevention. Number one, what is your experience around HIV prevention and women? And how are you doing more? Because I would guess no one has great uptake, but if not, how are you doing more? Second question is around post-exposure in pocket. So with PEP, you could actually prescribe it in advance, so people don't have to sort of rush to a provider in that 72 hours. And then, sorry, I actually have a list. And then this actually one is for Martha. Martha, in your work where you delay initiation by a month after a high-risk exposure, would you ever consider just prescribing a month for prevention and then doing a test and then moving on to prescribe 3 months, if I understood the slide correctly?
Before initiation of PrEP, we did screening for HIV. If the participant told us that had a high risk exposure, we delay the start to distribute PrEP.
One model.
1 month, and again we screening.
So one model people are trying is even with high risk exposure, especially considering your new
Our
diagnosis
program
rates
was only for high risk MSM.
Yeah, and so since you had so many new diagnoses, and I think also in Boston,
Yes, I had new diagnosis.
But would you ever consider just, even if they had a high-risk exposure, just prescribing a month, knowing, you don't know their status, but then doing the test again? Because in that month, they might have another high-risk exposure, and you're just delaying.
Yes, but they have take for 1 week PrEP every day. So they are, there's no danger. Like the studies. We need daily PrEP for 1 week. Have the rate of the drug in the organism.
Let's chat after. Okay.
I can say we definitely do PEP to PrEP often. So if people I would love to speak to your earlier questions, Mia. Also, so I think engaging people who inject drugs in HIV prevention services, I think, has been like historically difficult, and being able to offer low threshold screening where people are using is, I think, the number one thing, but also the retention and the engagement is really about relationships and sort of being consistently in those spaces and being able to, especially for people who are homeless, being able to get over the logistical issues around medication storage and pharmacy negotiation and things like that. And so so testing in SSPs or on the street, and I think I mentioned we do serum testing, we aren't doing point of care. Being able to be there consistently and incentivize that with, we have MacDonald's or Dunkin' Donuts gift cards is a very, very common thing. And then being able to write the script and actually having our staff get it at our pharmacy, which is in our building, which is next door to the SSP, but still like potentially a little too far away for people in the moment. And we do short scripts, which we recently were audited by an outside pharmacy, and they were like, you're not supposed to have Truvada out of the bottle for more than blah, blah, and we're like, fuck you. So we often do 7-day scripts or shorter, 7 days with refills, or we fill a month and we put it in our like harm reduction nursing med cart, and people get like a day or two at a time. So we engage many more women in those spaces, just kind of across the board. And then we also, unfortunately, the police pay people to pick up needles, but they don't provide them with the safety gloves to do that in a appropriate way. And so people get needle sticks all the time. And it's perverse. And so people come in often because they perceive risk, their own injection risk, or this community environmental risk. And so very, very often we're putting people on post-exposure prophylaxis. And I think one thing to say is we draw bloods, but we start meds that day, whether it's PEP or PrEP. And if it's PrEP, we do limit it to 7 days until we have results, but with a very close plan for, we will come find you here, or you come find us here, and we'll continue that prescription.
Great.
We also are doing a little bit of injectable PrEP, but I do not think it has had nearly as much uptake as we would have imagined early on, and now that there's lenacapavir data, and it's like, forget about it. Like, we need lenacapavir now.
Yes. Awesome, thank you.
Hi, sorry, back here. Yeah, wonderful to hear about folks' experiences. And what I wanted to ask about was nurse-led protocols particularly for PrEP initiation, but just in the space sort of more broadly, thinking about task shifting or task sharing, given the number of people who need access to a lot of these services, particularly HIV preventive care, and the limited number of prescribers, particularly physicians, but also advanced practice providers, particularly depending on sort of what country or what practice environment you're in.
Who wants to take that one on?
I can. I'm sorry. I don't mean to monopolize. We wrote a protocol and just got it through our clinical standards committee within our own organization. And it basically says if a nurse is evaluating somebody for HIV, for PrEP, if they don't, I think it's very, very clearly, like, if there's evidence that they do not have active Hep B and that they do not have signs and symptoms of acute HIV, you can like put the prescription in the name of our HIV program director for 7 days and then follow up from there. So it is pretty limited, but it's meant to we have to respond right now. And so how do we get medication in people's hands? And that was one of the ways. We've since lost the funding for our PrEP nurse, but the nurses that work in those outreach settings have sort of taken it on. But it basically is the same as like nurse standing orders for vaccination and like empiric STI treatment as well.
Tatiana Deshko, Alliance for Public Health Ukraine. It's just about a month since we initiated KBLA, as prevention in MSM group. And we've been, actually one of the reactions was people speaking about how painful the injection is, and wanted to ask for any kind of advice you would give. Is it really maybe enhanced counseling before kind of getting the person in, or any other kind of recommendation anyone in the room would have? Because I think this is one of the largest kind of reactions that we have had. Although the program is going kind of overall well and a lot of interest in it, but kind of just this. Yeah, thank you.
I'm not sure if anyone else has got something. I know that our sexual health team have started to keep lots of ice packs, and they actually have people lay down for a while afterwards, and they put an ice pack on just to kind of cool the area. But other than that, it's quite a thick, big injection. So,
we absolutely have had some people who don't tolerate the injection well. We've had a couple of people on rilpivirine discontinue and have had like exacerbations of sciatica, and like whether or not that was actually related, just they equated it with that. We have some people that get they get administered dorsogluteal instead of ventrogluteal, and that has been helpful for some people. You can do that. But it's not great, frankly. I mean, honestly, I think it's, I think of it as like telaprevir or boceprevir with hepatitis C treatment. It's like the beginning of a shift in practice, but it's intensive and it requires a lot of very tight monitoring, and it's painful, and those injections kind of suck. Like the next generation of this is going to be so much better for everybody.
All right, on that note, which has brought us right to time, I'd like to thank all of our speakers and our panel members and our audience plants and everyone who participated and came today. Please keep up the amazing work as nurses. We are so important as we head towards elimination for viral hepatitis, but also in all the other wraparound services that keep the person at the centre of the care we're providing. So thank you for coming today.